Neck deformities is quite common in children, and as you know that it's mostly the congenital deformities of the neck which are of orthopedic significance. For example, the most commonly it involves the congenital muscular torticollis. For example, if you see a child who's been born and there is a sudden neck tilting of towards one side. For example, if you see this diagram, there is slight tilting towards the right, although there is no chin deviation. Torticollis or congenital muscular torticollis is actually the problem with the sternocleidomastoid muscle. In utero, there is a compartment syndrome or development of compartment syndrome in the sternocleidomastoid, which eventually leads to necrosis, and this necrosis eventually predisposes to contractures of sternocleidomastoid. So when a child is born with the sternocleidomastoid, for example, a child is born with the torticollis of the right side, what would happen is that would mean that the right-sided sternocleidomastoid is actually necrotic and fibrosed now over time. As a result, there would tilt towards the right side and chin would deviate towards the opposite side. So this is usually a classical presentation with the child presenting with the tilt on one side and chin deviation or rotating towards the opposite side. And when this happens, this is actually sometimes associated with certain cord-like or even a nodule-like which is palpable in the neck, or sometimes there may be no nodule palpable at all as well. So when you are reviewing a torticollis, this is the classical deformity what happens. Now what has actually happened is that this is involving the left sternocleidomastoid. As a result, the contraction is over the left side. The head is tilting towards the left, but rotating, and chin is rotating towards the opposite side. So if it's a right side sternocleidomastoid, the tilt would be towards the right side, and chin and head would rotate towards the left side. But if it's the left side, it will be the tilt of the head would be on the left side, and chin neck would rotate towards the right side or the opposite side. As you can see over here, this is a contracted muscle which is actually causing the problem. Now, when we are reviewing this congenital muscular torticollis, what we need to remember is that it is sometimes called as association with the packaging syndromes. There are certain factors which we need to look at how to rule out, especially in the children with the torticollis. For example, could be the developmental dysplasias of hip, metatarsal adductus. They may all be associated as a part of the packaging syndrome. And the main pathoanatomy is because of the lie of the baby in utero is sometimes such that there is associated hip problems, there is associated foot problems, and there is associated neck problems as well. So what you need to rule out whenever you get a child with congenital muscular torticollis, that you need to do an Ortolani and Barlow test and make it sure that this patient does not have a DDH, and then you need to look at the feet as well to make sure this is not associated with metatarsus adductus. Usually this is the kind of an X-ray you get. You can appreciate the rotation of the cervical vertebrae. That is why, because the pull of the sternocleidomastoid is actually taking it to the other side. Now coming to the sign and symptoms of the congenital muscular torticollis. When a child is really born, it presents with symptoms like there may be associated with a nodule or a palpable mass which could be palpable in the neck. Sometimes what happens is the sternocleidomastoid may get fibrosed large enough that it may lead to some form of nodule formation in the neck. There may be associated sign of infection or discitis. Patient may present with pain, with a fever as well, but usually it's rarely a situation where the problem becomes so immense that it may be associated with infection. Most commonly, it's kind of a tilting head with a painless mass or a nodule over the neck area. Or it may be caused by the ear or upper respiratory tract infection, which may lead to eventually some form of a torticollis. And it may be caused by cervicothoracic scoliosis. Now, scoliosis is also very common in children, especially if it is infantile form. which is more aggressive and which usually involves the upper thoracic and cervical spinal vertebra. The problem may be actually in the spinal vertebra itself. They may be rotating, or they may have a wedged vertebra, or they may have a hemisegmental or segmental vertebra, in which there may be associated problems of the rotation of the cervical spine, in which actually the tilting of the head is not due to the problem with the sternocleidomastoid, but the growth of the cervical vertebra occurring such a way that it's actually leading to tilting of the neck or rotational deformity over the neck. Now, whenever we see a child with this kind of a problem, first and foremost, as I told you, we have to get a history, then clinical examination. Once we are sure that most likely sternocleidomastoid fibrosis and eventually leading to torticollis, then we may have to get x-rays. X-rays could be as simple as cervical spine AP and lateral view, and it may involve other views as well. As I just told you that it involves, it's a part of a packaging syndrome. There may be associated DDH as well, and even metatarsal adductus. So sometimes you need to get the views of x-rays of pelvis as well as the foot as well. Now this is a child. You can appreciate that the cervical spine looks good. There is no associated abnormality, but the head is actually tilted towards the right side. So most likely this is involving the torticollis of the right, with the rotation and chin going in opposite direction. Similarly, sometimes you may have to have an MRI as well. They may be associated like syringomelia, or underlying the neuromuscular problems may be present. As a result, the neck is actually going into this kind of a tilt and rotation instead of having a congenital muscular torticollis. For example, you can appreciate it over in this MRI. Now, if it's an infantile or congenital torticollis, this is usually a classical picture, and this is as this child is quite old. Usually, even in the first year of life, you can very well appreciate the tilt of the neck, and which is very much visible. So usually, if you see this child, what do you think the problem is on which side? The problem is on the right side. It's on the left side of the child, as the tilt is towards the left side, and the neck is actually going towards the rotational profile of the neck, and the chin is going towards the right side. Now, as we know that there is associated with actually packaging syndrome. So most commonly, these packaging syndromes may involve problems with the foot, for example, congenital metatarsal adductus, or there may be associated during the birth injury when the patient has been taken out, or this may be associated with the developmental dysplasia of the hip, because the lie of the child may be such that this may be leading to a lot of problems of the hip, foot and neck area. Or there may be history of breech delivery. Now, breech delivery actually predisposes a child to multiple issues. For example, in breech delivery, if the child is lying like this, the hip is usually resting over the pelvic brim, which can cause DDH. As the feet are actually resting just below the muscles, therefore there is always a chance of having a metatarsal adductus, and the baby's neck is actually lying quite deep into the body of the mother. That is a result. This may be associated with muscular torticollis. So the breech delivery is actually the main cause of development of all these packaging syndromes, which may manifest as developmental dysplasia of hip, congenital muscular metatarsal adductus, or congenital muscular torticollis as well. Now, why we need a CT? The CT is actually required to rule out two differentials which are very important in CMT as well, or congenital muscular torticollis. One is Klippel-Feil Syndrome, and other is Atlantoaxial rotary instability. For example, if you see this is probably showing the most likely the cause is in the muscle. As you can appreciate that the vertebra are aligned properly, and there is no actually fusion of any of the vertebra. For example, CT is actually done to rule out other two differentials. One is atlantoaxial, that is C1, C2 instability in children, and the second is the Klippel-Feil syndrome. Further continuing with the x-rays, if you can appreciate it over here, there is definitely some tilt. Now, if you see the tilt is chin is going this direction and head is going in this direction. So most likely the problem is of this side. The tilted side will be where the problem would be, and chin and neck will rotate towards the opposite side. Now coming to the treatment. Now that actually depends whether what is the age of the child, and usually the infantile or congenital form is diagnosed within the first year of life. So mostly it is actually the initial treatment of any congenital muscular torticollis is the passive stretch, that is the physiotherapy of a child. There are special physiotherapists which are available and in which you can also educate the mother to stretch the neck towards the opposite side. For example, the head is tilted towards the right and you know the problem is on the right side, you can gradually tilt it towards the left. And so by excessive passive stretch, you can eventually correct partially you can correct the deformity. And eventually if the deformity does not correct by more than 1 year, then you can go for some form of a surgery. Usually if the tilt is less than 30 degrees and it's a mild deformity with no nodule palpable in the neck, you have to go for passive stretch, and passive stretch can also be done early on for the disease as well. And once the child has passed beyond 1 year of age, then probably the option lies, a surgical option has to be considered, for example, which includes a Z-plasty or a bipolar release. That is only if the deformity is greater than 30 degrees and the child age is more than 1 year, you have to go for bipolar release of the congenital muscular torticollis. Now there is a term called as secondary torticollis. The child was okay, he was born okay, there was no associated neck problems. But later on in the stage, at an adolescent age, he developed this kind of a problem. Now then later on, once this problem starts, this is most likely not the primary pathology of sternocleidomastoid, but the problem lies actually in the some other cause which is actually causing the neck to deviate in certain direction. So most likely the causes which includes the secondary torticollis include, it could be some form of infection or lymphadenitis, which is lymph node is impinging in such a way that it's causing neck deviation and muscle spasm. There may be associated with the tumors of the posterior fossa, especially of the posterior triangle of the neck, which may be causing this kind of a problem. Or it may be associated with inflammatory disorders as well. For example, juvenile rheumatoid arthritis may have this. Patient with these JRA may present with this kind of a problem once the JRA becomes exacerbated. Or there may be associated neurogenic causes or traumatic causes which may be leading to, for example, there was trauma or injury to sternocleidomastoid, later on fibrosis occurred. That fibrosis is actually now causing the pull or tugging the actually neck towards the tilting it towards one direction, leading to congenital type of a, or this secondary type of a torticollis which may have developed over the course of the time. Now coming to another very important, although very rare disease called as the Klippel-Feil Syndrome. Now this is usually associated, this is a kind of acquired form of a muscular torticollis which usually occurs in children of adolescent age. What happens is the child was absolutely normal previously. He or she develops some form of a flu-like symptoms, like most likely an upper respiratory tract infection or even a respiratory tract infection, which may eventually lead to later on this kind of a torticollis of the neck. Child when presents to you usually presents with tilting of the neck, and the parents say that he or she was absolutely normal a few weeks ago, but suddenly now she has developed over 3, 4, 5 days over time, she has developed this acute pain, this tilting of neck. And when you dig into the history, this is usually associated with some form of a respiratory or upper respiratory tract infection. And although this is quite rare, but this may be the torticollis, which is a secondary form of a torticollis, may present with the Klippel-Feil syndrome, and you need to make it sure that once the infection would settle down, eventually this would require some form of passive stretching, NSAID, so that it becomes less painful. And once the sequelae has finished, then you can think of either to continue with the physiotherapy or go for some form of a surgery. Then another term which is very important, which is kind of overlap sometimes some symptoms of torticollis are, is actually Atlantoaxial rotary subluxation. Now what is important to understand is that we have in our body the first two vertebrae. One is the atlas, which actually forms a joint with occiput and called as occipito-atlar joint, and then you have atlas and axis, which form the joint between the atlanto axial joint, and which is actually the C1 C2 joint. Now there is rotary subluxation may present in children, especially which had undergone recently head and neck surgery in form of a tonsillectomy, or there may be associated with upper respiratory and nasopharyngeal tract infection, and they may undergo some form of a head and neck surgery to drain a retropharyngeal abscess. Now, usually during this surgical procedure, there may be iatrogenic injuries to certain ligaments, such as the transverse ligament, apical ligaments, or LR ligaments, and eventually post-surgery, this eventually once the fibrosis develops, they may present with atlantoaxial rotary subluxation, which would mimic the signs symptoms of torticollis, but usually it's slightly different entity as compared to the torticollis. Now you have to, for atlantoaxial subluxation or even rotary insufficiency, you have to look at the x-rays first, and the first and foremost, which is more important, is actually to dig out the history. Then you have to look closely at the AP and the lateral view of the cervical spine. You can also get a lateral mass views of the open mouth view of the for to see the lateral masses of the second cervical vertebra. What is important over here is to mention that in pediatric, this may be degenerative causes such as atlantoaxial rotary instability or Morquio syndrome, or they may be associated with traumatic causes such as odontoid fracture, second vertebral C2 fracture, or they may be associated with C1 fracture. Now in adults, usually the degenerative diseases involved such as rheumatoid arthritis, or even problems like Down syndrome. But most commonly it's associated with the traumatic injury toward the C1 C2 joint. So when we get AP and lateral view, what we need to look at is that we need to look at carefully over the C1 and C2 joint, and then we have to rule out underlying secondary cause which is actually causing this sort of a rotary instability. For example, you can appreciate over in this, there's a mass which is actually impinging and actually leading to tilting of the or eventually torticollis formation of the neck. Now when you are going for the treatment, you first and foremost is to establish the cause of the disease. Once you establish the cause of the disease, then you are probably going to be moving towards the what you need to treat. Most likely, sometimes depending upon what is underlying cause, we need to look at different angles as well. We need to look at what is the RD, what is PARD, depending upon whether there's loss of transverse ligament or not. And then once assessing everything, then you realize that probably you can go for halter traction in children. One way of doing is, or simply even bed rest or cervical collar is sometimes enough. Analgesics may be needed initially to relieve the child of the pain, and hollow traction may be advised as well. But depending upon what is actually the causing the torticollis and what is underlying problem, that for example, if underlying problem is rotary subluxation or instability, then you need to identify what is actually cause which is causing this sort of instability and address that. If for example in Down syndrome, or if it's due to juvenile rheumatoid arthritis, most likely the problem is with the ligamentous instability. All you need to do is to give NSAIDs and give a collar so that the problem gets dissolved over time, because the problem is actually not in the bones, but problem is the ligamentous laxity. But if it is actually due to the trauma, or if it is actually due to problems with the for example ligamentous problems with the transverse ligament, then probably the treatment is towards fixation, and we may require C1 C2 fusion in the children as well. Now treatment, it could involve multiple options, as I told you, depending upon the cause. It can involve non-surgical options such as hollow traction, even NSAIDs, cervical collar, or it can even involve as well the fixation or C1 C2 fusion, or even hospitalization of C1 and C2, and may involve the fixation from occiput to C3, depending upon if there is marks instability and there is always a chance that canal may get compromised, then you may need to fix it completely. There is another term called as the Klippel-Feil Syndrome, which is always associated with neck abnormalities in children. When we are dealing with congenital muscular torticollis, what we need to remember is there are two differentials to congenital muscular torticollis. One is Atlantoaxial rotary instability, and the next one is Klippel-Feil syndrome. Usually, it is actually a problem with the abnormal fusion of the different segments of the cervical spine. For example, there may be a fusion of C2, C3. There may be a fusion of C1, C2. There may be fusion of C6, C7. So maybe abnormally the cervical spine get fused. So what happens is I'm tilting my head like this is rotary movement. This is actually the 50% of the rotation movement is actually occurs at C1, C2. When I'm doing like this is flexion and extension. Now 50% of the flexion extension actually occurs at the subaxial spine. So the symptoms, there is a classical triad of the symptom, and usually child classically presents with this low hairline. If you can appreciate it, it looks like the neck is almost absent. This head is kind of rightly just lying side to the torso, and there's very less amount of neck which is very much visible. Usually associations could be towards multiple diseases. It involves abnormal scoliosis, which is very much common with the Klippel-Feil syndrome. There is problems with the cervical spine and thoracolumbar spine as well. Then it may be associated with renal anomalies such as abscess, or actually even problems of such as small kidneys. Then there could be associated with congenital heart diseases, and sometimes it may be associated with springal deformity as well. A springal deformity is actually there is an omovertebral bar formation over the superior medial aspect of the scapula, which connects it to the cervical spine. So the problem is actually that is not purely in the neck, but is extending towards the shoulder, and usually these children present with scapular hyperplasia, as well as maybe associated the winging of the scapula as well. So this there is other association as well, which may involve multiple other areas, such as along with the heart. They may involve GIT, they may be vector syndromes. All this may be associated with the Klippel-Feil syndrome, but usually very rarely. Now this may be associated with deafness as well, as I just told you, or there may be a thumb hypoplasia, deafness. These are although very rare, but they can occur with the Klippel-Feil syndrome, such as syndactyly, as well as even having an extradigital or polydactyly. Now, all these deafness, thumb hypoplasia, syndactyly, polydactyly are highly rare in Klippel-Feil syndrome, but they can occur associated with the Klippel-Feil syndrome. Usually classical triad, as I told you, the classical triad includes the three things in it. And if you see this X-ray clearly, now this is actually a large version of the cervical spine. Now this is likely C3, 4, 5. This is a fusion of C6, C7 along with the T1 as well. If you see it clearly, this is actually subaxial fusion. And if you see it over here, this is a large view. Probably the fusion between the two cervical vertebrae is very much visible. The classical triad is synostosis or short neck. There is actually low hairline and short neck is actually present. Then is the various degree of neck webbing. When you view it from the proximal or from the front, there is actually neck webbing, low hairline, short neck, and above all, you have actually limited neck range of motion. As I told you, depending upon where the fusion is, if it's in the C1, C2, probably there will be deficiency of rotary movements, that the child will not be able to do like this. And if there is actually below subaxial spine is involved, that is C3 and below, then the problem will be the flexion and extension, and child may not be gross, but definitely some degree of movement will definitely be hampered, and either the rotation or even the this would be a problem, especially if it's subaxial spine, the flexion extension would be grossly limited. Now, for any disease, once we have taken the history and examination and we are suspecting differentials, when we make the differentials, we go for X-rays. In imaging, usually you have to go for AP and lateral view. And on AP and lateral view, you can classically appreciate the synostosis or fusion of the different segments. You may have to go for ultrasound to rule out other abnormalities such as renal abnormalities and GIT abnormalities. Along with, you may have to go for some form of cardiac testing as well to rule out cardiac anomalies as well. And this is actually showing the image of if you see it over here, this is involving the C1, 2 and 3 and 4. All this part is actually synostosed or fused. And this is also another view of the same thing. C2, C3, C4 vertebrae, you can see it, they're most likely fused, and this patient will have a gross problem with the rotational movements of the neck. Now coming to the treatment. The treatment is actually divided into mainly two things. That is whether the problem of the segment fusion is above C3 or it's below C3. If it's above C3, then really what you need to do is that you need to tell the parents that this child needs to avoid contact sports. If he or she is going to continue with the contact sports such as American football or rugby, there is a high chance that he or she may eventually end up having a complete paralysis, and quadriplegia can be very disastrous. So if it's below C3, then yes, you can allow them to have increased movements and things like that, but actually that would although they would still be at a risk of having a cervical spine injury, but at least they can be allowed to have a contact sports. Sometimes what's the treatment then? Treatment sometimes involves cervical fusion. That is, if they're actually having a problem, we can go for cervical fusion. And as I told you, above C3, you need to avoid contact sports. Now coming on to atlantoaxial instability. As I told you, among one of the most important differentials of congenital muscular torticollis is Klippel-Feil Syndrome and atlantoaxial instability. Now what happens is it's kind of a rotary instability between C1 and C2. It may predispose patient to some form of a spinal cord injury, as the C1, C2 may subluxate or even completely dislocate due to asynchronous rotary instability. Now in adults, the most commonly caused, there could be divided into traumatic and non-traumatic causes. Among the non-traumatic causes, the most commonly includes the Down syndrome and the rheumatoid arthritis and problems such as os odontonium. While the traumatic causes in adults mainly involve the C1 fractures, C2 fractures, and eventually problems with the such as traumatically fractures involving the occiput along with the C1 and C2. Now in pediatric population, the main cause of the rotary instability include juvenile rheumatoid arthritis, Down syndrome, as well as Markov syndrome, but a traumatic cause may only involve atlantoaxial rotary subluxation. Now what happens is, as I told you, there is increased risk, especially in the case of os odontonium, which is actually, if you see clearly, there is odontoid process is of the C2, which is actually has a body. It has two different fusion centers, and once these fusion centers develop, they fail to fuse. This failure to fusion of odontonium is actually termed as os odontonium, and when you get an X-ray, it depicts the kind of as if there's odontoid fracture, but usually it's not a fracture, rather it's an incomplete fusion of the odontoid process in a normal adult. Or it could be such as the occipitalization of atlas, in which actually atlas has gone more towards the occiput rather than and away from the axis, leading to asynchronous atlantoaxial instability. Or this may be associated with basilar invagination. All these includes a patient increased risk of having atlantoaxial instability. Now coming to the properties. What happens in atlantoaxial is that it's more common towards the Down syndrome, and Down syndrome and rheumatoid arthritis may present with C1, C2 instability. This may be due to secondary of the laxity of the transverse ligament. Now the problem is such that usually if you see the anatomy of C1, it's like this. It's actually a quadrangular shaped C1 in which the axis is actually the odontoid process axis is actually rotating like this in form of a hinge. What happens is the transverse ligament is maintaining that hinge. Once if that transverse ligament becomes relaxed, this leads to subluxation and instability of that hinge, which is actually articulating at C1, C2 level. And usually CNS becomes less tolerant of intermittent compression, which is actually more problematic because once it starts impinging on the spinal cord, this may eventually lead to traumatic injury of the spinal cord. Now, whenever we have to get an X-ray, we always get to AP, lateral, and open mouth odontoid views to rule out atlantoaxial instability. On AP, we will see what is actually situation of odontoid, whether it's associated osteotomy or not, whether there is any fracture of C1 or C2 or not. And on lateral view, we will probably see the basilar invagination as well. Then to exactly calculate what is the situation and what is the risk for subluxation in the person, we need to calculate two parameters. One is that ADI or RD, and the other is PADI or PADI. What is ADI? That is actually Atlanto-Dells interval. As you know that this is where the dens is, and this is part you get calculating this distance up to this distance is actually Atlanto-Dells interval, or actually it's an anterior subluxation how much that actually the axis can go away from the atlas. But if this is actually increased, then normally it should be less than 3.5 to 5 mm. But if it is more than 5.1 mm, this is usually denotes that there is maybe associated injury to the transverse ligament, which as a result that actually the dens is displaced into the spinal cord, leading to increase in the ADI. Then there is PADI or posterior atlanto-Dells interval, which is actually equivalent to spinal cord volume, or you can say space available for the spinal cord, or SAC. Normally 17 mm of space is available for the spinal cord. Usually 14 to 17 mm is considered normal, but if RD increases, actually the dens has gone more back, therefore the space which would be available for the cord would decrease. Therefore, in 10 to 14 mm it's at risk, but less than 10 mm is an absolute indication to intervene because the space available for the cord is too low or too less. And you have to look at the calculate the RD and then space available for the cord, or PADI, or posterior atlanto-Dells interval. And when you get a lateral view, usually you see an basilar invagination, which may be seen due to the cause of the atlantoaxial rotator instability. Now coming to the treatment. Treatment is actually directed at the cause. If what is actually causing this instability. If it is associated with fractures, then you may require fixation, or if it's osteodontonium, you may have to leave it as such. Osteodontonium is actually a normal variant, and it's actually normally present and does not actually means that there is a fracture of the odontoid. Now, depending upon what exactly is the cause, you need to know that how much instability is there, what is the ADI and what is the PADI. Then you may, depending upon the clinical situation as well, if the patient is presenting with the radicular symptoms, may require initial treatment and to just reduce the subluxation. But if there is a myelopathic symptom and neurological compromise which is occurring, then you may need to fix it both anteriorly as well as posteriorly. Now coming to another problem of the neck problems are mainly associated with the spine is the acute intervertebral disc prolapse. As you know that in spinal cord there is on outside there is actually annulus fibrosus, which is a tough structure which is holding and providing stability, and then on side there is a small nucleus pulposus. Now what happens is that usually this annulus fibrosus has micropores. It's a very tough structure. It does the fusion of the particles which are actually required for the nourishment of the nucleus pulposus goes through these micropores. What happens is, despite all this, there may be associated with degenerative problems, and this results in actually the rupture of annulus fibrosus. And as a result, due to the pressure effects from on axial loading or during forward flexion and extension, what happens is the nucleus pulposus protrudes out of the annulus fibrosus into the spinal cord. When it comes out, this is called as acute intervertebral disc prolapse. This may usually most commonly occurs at the lumbosacral level or can occur at the cervical level as well, but most commonly it is due to the lumbosacral problems, which is results in this kind of a problem. Now, what happens is that there are certain causes which precipitate it actually. It may be precipitated by local strain or injury. There may be predisposing anomaly of the disc. The problem may be due to the degenerative, for example, abnormality. This may result in this kind of a situation. Or there may be intradural disc herniation, which is actually although very rare type, but it can occur as well. And what we are sure, we need to make it sure that this is not the problem which is actually occurring over there. Or then what we need to know is that there may be extruded material into the spinal cord. Usually it disappears over time, but it may be what we need to remember is that we need to give patient assurance that it's gonna, if it's not causing a neurological compromise, it's gonna go away. Now coming to the clinical features. Clinical features are most commonly, it's always a unilateral pain. Usually patient presents with low back pain relating to either the right or the left side of the body, but sometimes the disc bulge may be so huge that it's actually leading to bilateral pain actually. Then if it's cervical, this may be associated with the neck pain, and if it's lumbar, it may be associated with the back pain. There may be radiculopathic symptoms, that is nerve irritation. For example, if C5 nerve is getting irritated due to disc prolapse, there will be problem with the C5 actually is on the regimental badge area on the shoulder. That is there may be dysthesias over there. There may be decrease in the elbow flexion, and there may be other problems as well. Now, if the L1 or L2 root is getting disrupted, the problem would be over the inguinal canal and the anteromedial aspect of the thigh. Depending upon which nerve root is getting irritated and getting involved, there may be a dermatomal presentation of the nerve irritation symptoms, eventually precluding to radiculopathy. And then, as I told you, there may be associated paresthesias, hypoesthesias, radiculopathy, and nerve irritating symptoms. And what is important is that you need to rule out whether is it nerve irritation which is occurring, or is it just a myofascial spasm which is actually exacerbating the patient's symptom. Now coming to the clinical features, these include, as I told you, decreased reflexes and motor weakness. Eventually, the radiculopathy may progress to myelopathy. Usually the most affected areas are the C5, C6, and C6, C7 in the cervical spine. Then pain may be radiating towards the scapula and the occiput. If it's involving the C5, C6, the nerve which would be affected would be the C6, because that is actually going below the level of the C5. And what actually happens is the C6 involves, there would be dysthesias, problem of numbness mainly over the radial aspect of the forearm, and thumb and index finger may have hypoesthesias as well. And if it's C6, C7, the nerve would be affected with the C7, and that would affect mainly the area over the middle finger, as well as there may be associated with a decreased flexion and loss of tricep reflex. Now, there may be a problem with the torticollis. If it occurring in the children, this may present with the neck painful movements, or even the torticollis of the neck as well. Muscle spasm and tenderness is quite common, and mostly the symptoms of myofascial fascicle spasm overlap or overshadow usually the acute intervertebral disc prolapse. Continuing with the clinical fracture, the most commonly it is associated with pain on the movements, that is acute neck flexion, maybe presents with the increased irritation over the neck. This term called a Sperling test, in which actually the neck is first extended and rotated towards that side, and if the radiculopathic symptoms are involved, this will actually produce the pain and numbness sensation over that dermatome of the involved area. There may be pain and stiffness, along with the residual axial pain and slight neck stiffness involved. On an examination, we may have to go for Sperling sign, which will elicit whether there's isolated myofascial spasm, or actually involving the radiculopathy, or even this is actually gone beyond the radiculopathy, eventually leading to myelopathic symptoms. And sometimes we have to check for the rotation of the neck as well. just to rule out whether it's associated with radiculopathy or myelopathy. Now coming to the imaging, whenever we get the cervical disc prolapse, what we need to remember is that first and foremost is we have to get AP and lateral view of this X-rays. Or AP view, usually you will see there may be normal cervical vertebra. On lateral view, you may have this reduced disc spaces at times, but there may not be a lot of symptoms which would be present. Sometimes this muscle spasm actually increases the distance between the C1 to C2 spinous process, but usually it's normal. Once we have get the X-rays, then we have to go for MRI. Now what would MRI tell us? If you see this MRI closely, this is a T2 weighted MRI, and if you see this is C2, 3, 4, 5, 6 and 7, there is actually a disc bulge between involving C6, C7 and then C7, T1. Now this would mean that there will be involvement of C7 and C8 nerve roots, and which would present with middle finger dysesthesias, hyperesthesias, little finger anesthesias, and the paresthesias over the other side of the forearm. Usually this is what happens. You have to get all the views, pre and post operative X-rays. Mostly you don't require an operative fixation, but if you are going for operative fixation, depending upon how much canal compromise, then you need to get pre as well as the post operative X-rays. Now coming to the differential diagnosis, what you need to remember when we are dealing with acute intervertebral disc prolapse. What most commonly it may be simple myofascial pain, or it could be a acute soft tissue strain. There may be some micro tears, especially in the gymnast, or they may be associated with athletes as well, or there may be cervical spine infections. Actually, the cervical spine infection may be causing the stiffness and actually nerve irritation, that is why the patient is presenting with radiculopathic symptoms. Or it may be associated with neurological amyotrophy, which is another disease which involves the problems with the basically neurological autoimmune disease, in which the amyotrophic lateral sclerosis may have been occurring. And then there may be cervical tumors, although rare over here, but yes, they sometimes can impinge on the nerve and may present with radiculopathic or myelopathic symptoms. And lastly, you cannot rule out the shoulder. Sometimes what happens is the problem is the neck, and patient is actually presenting with the primary problem of the shoulder pain, and you have to delineate whether is it the shoulder which is the problematic, or is it the neck who is having actually the problem. And this is what exactly happens. Sometimes the pathology is in the rotator cuff. Patient, when you dig up the history, there was previous history of trauma to the shoulder, there's a problem with the movement of the range of motion of the shoulder, and then the patient is actually presenting with radiculopathic or myelopathic symptoms. That is why sometimes the shoulder pain and the cervical pain actually overlaps, and you have to get detailed history and examination to rule out whether the problem is in the cervical spine or is it towards the shoulder joint. Then treatment, with mostly they usually involve a conservative treatment. First and foremost is the patient education. Then you need to tell that this patient needs to take rest and avoid activities, for example lifting heavy weights, so that it does not lead to recurrent episodes. Then bed rest, depending upon what type of injury it is, usually it requires 2 to 3 days of bed rest, not more than that. Steroids rarely given, but can be given if the acute symptoms are quite too much, but mostly NSAID and neuromodulators are more than enough. Steroid injection may be used, but usually it's not the first choice, especially if the patient is presented for the first time. But with the recurrent, you may require some form of steroid injection. Cervical collar, bed rest, and NSAIDs are usually the mainstay of the treatment along with the physiotherapy for that person who was presented for the first time. But if it's presenting with a recurrent minor episode, then you may consider steroid injection along with the patient education, so that the patient does not have frequent episodes of recurrent herniations. Now, if the patient is having recurrent episode, or it's one large problem and the extrusion of a large disc and is actually leading to neuromuscular compromise, or presenting with the myelopathic symptoms, then you may have to think of some form of a surgery. And usually if it's in the cervical spine, you have to go anteriorly as well and fix it, as well as posteriorly. Simple posterior fixation is actually not an option. So you have to go for ACDF or actually this is called as anterior corpectomy as well as discectomy along with the fusion, that you go in through anterior approach, you remove the corpus, all the vertebral body, and as well as remove the disc, and then fuse it anteriorly as well as posteriorly so that it becomes more stable. It usually the indication includes myelopathy. If there is a changes on MRI, or there may be associated with neurological compromise, and if the patient's clinical improvement has not resulted despite a lot of conservative treatment over maybe which may have stretched over months. Treatment is mostly ACDF, that is anterior corpectomy and discectomy along with the fusion. Usually this is taken for in the case of the cervical spine. Other options which may involve, for example, for the cervical spine is nowadays there a minimal invasive approach in which microdiscectomy and posterior foraminotomy may be done, so that only if it is actually the problem is at the transforaminal level or far lateral level, the posterior foraminotomy may only help to relieve the patient of the radicopathic or myelopathic symptoms. Other options could be disc prolapse surgery, is one of this called as actually the cervical disc replacement or CDR. If you see this is the post-op x-ray of a cervical disc replacement in which the disc is actually been replaced by some other form of material so that actually the movement can be restored back, because usually the fusion although cures the patient of the problem, but this results in actually the loss of movement. So the cervical disc replacement is actually a new technique which has been introduced so that the patient can get rid of its problem. Along with it, what happens is that there is actually no gross limitation of the movement, because once you fix the spine anteriorly as well as posteriorly, then the movement, that is flexion extension or rotary movement, cannot actually take place. Thank you very much. Keep watching sqadia.com.